Greetings and welcome to our webinar, Ensuring Quality Health Services, Complex Issues, Emerging Opportunities. To connect to the audio portion of this meeting, you can choose Call Using Computer. If at any point you have problems with the audio, you can choose Change Settings. If you prefer to connect by telephone, you can choose I Will Call In. Use the telephone number, access code, and attendee codes that are provided. There are several international call-in numbers should you need it. You are welcome to ask questions at any time using the Q&A panel on the right side of your screen. Select Q&A and be certain the option is set to ask all panelists so that we can see your question. If you need any support, you can send a question directly to the host or to me, Jean Goodman. With that, I would like to introduce your moderator for this event, Midori Dehabich, Technical Director, Local Health System Sustainability Project, LHSS, former Minister of Health, Peru.
Thank you so much, Jean, and greetings to everyone with us for today's webinar on ensuring quality health services. I'm Midori Dehabich, and I will be moderating the discussion with our three distinguished panelists. Our topic today has been at the front of my mind lately. I am the Technical Director of the Local Health System Sustainability Project, USAID's new flagship activity in integrated health system strengthening. Improving the quality of health services is a big part of the project's mandate, along with reducing financial barriers to health care and ensuring equitable access to care. Because we know that making health care affordable and accessible won't matter if the health care that people receive is of poor quality. Our three panelists bring unique and valuable perspectives on this topic. We will begin with a short presentation from each of them, followed by a discussion. We have allowed a full 30 minutes for the discussion because we want you, our audience members, to have a real chance to ask questions. Whether you're new to the topic or an expert, we want to hear from you. Our first presenter is Soji Teti, who will give us an overview of current global thinking and framework around the quality of health systems. Over to you, Soji.
Thank you very much, Midori. For many people, 2018 was framed as the year for quality, mainly because of the three seminal global reports that were issued by the Lancet Global Commission. The WHO, OECD, and the World Bank also issued another report. And the final report was issued by the National Academy of Sciences, Engineering, and Medicine in the United States. Next slide, please. So all of these reports then framed the global conversation around quality using different frameworks. And if you take a look at the framework on top, that really was produced by the Lancet, they then looked at it through three lenses: the quality impacts, the processes of care, and then some foundational elements, and made a strong point that really once we are talking about quality, the conversation needs to shift from a focus on the inputs to the outcomes. And they talked about better health in terms of mortality, morbidity, and then also talked about economic benefits, that ill health should not result in catastrophic health expenditure, and then introduced an interesting concept of confidence in the health system, where they said we needed to, in addition to addressing issues around satisfaction, also needing to address concepts of trust, recommendation of the health system, care uptake, and then retention. And as you recall, at the height of the Ebola crisis in Liberia, one of the key issues had to do with lack of trust in the health system, for which reason people were, in essence, even avoiding it. As far as the processes of care are concerned, they talked about the competence of care. So how effective is care that is delivered? To what extent is it influenced by the evidence base? How correct is the diagnosis when people come to the facility? And then on matters relating to the positive patient experience, delved into issues relating to respect, dignity, privacy, and confidentiality. All of these were hinged on what they talked about as foundational elements. So the population, the various communities, addressing the needs of individuals, patients, and then the populations, the governance issues around financing of healthcare, the policies, using insurance and other funding mechanisms to be able to drive attention to quality, the various platforms in terms of how healthcare is organized, addressing the needs of the healthcare workforce, and then providing the tools to be able to deliver the quality of care. And then that then took some focus to the framework that was produced by WHO, really talking about how we could provide patient-centered care, because they were very ambitious in talking about the fact that we should look at universal healthcare, not just in terms of access, but really putting quality care at the center of it and making sure that everybody has access to quality care. And all of the issues around empowering health, coordinating care, looking at the continuum of care from communities right up onto tertiary specialist services, strengthening the governance functions. So really a number of concepts that are related and that need to be looked at in order to be able to address quality in a very holistic manner. Next slide, please. So this then brings me to some work that was done by the Institute for Healthcare Improvement. And IHI has been supporting a number of ministries of health and governments to develop and implement national healthcare quality strategies. So we just took a snapshot of some of the work that have been done in 5 countries, conducted case studies to be able to learn from their implementation experiences. And these countries were Ghana, Nigeria, Mexico, Scotland, and Ethiopia. What does it take to develop your strategy, and what does it take to implement, and what are some of the key lessons that could come from there? And we then identified 4 key phases. A phase of commitment, where one talked about what may be described as a spark. In Nigeria, for example, there was an incident that received an adverse press reportage, and then that sparked a lot of courageous action from the Minister of Health. So then, at multiple levels, they galvanized a number of stakeholders to be able to take this forward. So in many instances, there's a leadership that is required, not just at the political level, but also at the various technical levels, where stakeholders, including patient groups and patient communities, are put together to align this. Then there's the phase of the development, where having forged a cohesive agenda around what the need is, we begin to put together what the current thinking is in terms of the various activities that one needs to plan with, and the structures that need to be put together at multiple levels of the health system, national and subnational, to be able to address the quality of care issues. I think within that phase is also the emphasis on the local quality definition. Yes, we have the standard, dimensions of quality put out by the IOM, but you would see that from the global reports, there are interesting additional dimensions coming in. One is integration. That for a while, quality has been approached, from some sort of a fragmented perspective. So we need to provide integrated services for that patient that steps into the facility. One has to do with integrity, that the resources that are made available, for example, should be made available to serve the purpose for which they are provided. So it's important that all of the countries and the sub-health systems have an opportunity to locally define what quality means for them and what emphasis needs to be put in place. And then that takes us to the implementation. And the key thing to point out there is the need for a detailed implementation plan. There are some strategies that tended to be very high level, very strategic, with very little guidance on what frontline workers and people within various districts could actually do at their level to drive the quality of care. And it was interesting that in some instances we saw that the strategies had been costed, and this then enabled the conversations that the ministries were having with various partners to know which aspects best align with their own strategic interests. So that was also very key. And then a system that helps us to identify gaps and put in place measures to be able to address them on an ongoing basis while spreading the best practices as part of the sustainability agenda. So this is a framework that is emerging from that learning, and I will pause here. So thank you again, Midori.
Thank you so much, Soji. You've given us a lot to think about, and I would like to remind our audience to send in their questions for the Q&A last part of our webinar. Next, we have Ernest Konahu Asiedu, who will present his experience. Over to you, Ernest.
Thank you very much, McDory. I'll just take it right from where Soji left off. So Ghana is one of the 5 countries that benefited from the support from IHI in developing our national healthcare quality strategy. And I must say that our strategy is a 5-year document starting from 2017 up to 2021, which was actually launched December 2016. And our goal is to continuously improve the health and well-being of all Ghanaians or people who are resident in Ghana through the development of a better coordinated health system that puts the patients at the center of care. Basically, I will be talking about 5 different things around the capacity building and then also how we've been able to implement the strategy. But the first one is about the governance, the setup of the quality management unit at the ministry's headquarters. The second one I'll talk about will be the National Quality Technical Committee that runs the activities of the quality strategy. Then the pre-service curriculum to build capacity at the level of training, and then also facility license, which is the beginning of moving forward as far as quality is concerned. So the quality management unit was actually established in 2017 within the Policy Planning, Monitoring and Evaluation Directorate, basically to coordinate all the quality and safety activities or events within the agencies of the Ministry of Health and the Ministry of Health headquarters itself. It acts as a secretariat for the National Quality Technical Committee, and then also conducts research and then quality, and then coordinates a platform to showcase our quality initiatives within. Next slide, please. So the National Quality Technical Committee, which is actually chaired by the Chief Director of the Ministry of Health and operationally being led by the Director of Policy Planning, Monitoring and Evaluation, meets quarterly to deliberate on quality and safety issues within the health sector. The committee members are actually drawn from each of the agencies, and they are technical persons who are able to meet this every quarter to discuss quality-related issues. And then each of the representatives actually reports back to the head of the agency. And ultimately, whenever recommendations are made at our level, this is packaged and sent to the Inter-Agency Leadership Committee, which is actually the heads of agencies. And the committee is chaired by the Honorable Minister for Health. Next slide, please. So out of this, Objective 3 focuses on how patient and community can be active participants of the care. And the Africa Leaders Malaria Alliance supported Ghana in developing our community scorecard. And the community scorecard has 9 indicators that we work with, some of which look at things like caring, respectful, and compassionate care, and looking at waiting time, availability of medicines, diagnostic services, and then also things related to accessibility of insurance. But this tool is on the Ghana scorecard and provides feedback and accountability. This is also one of the countries that has the tool linked to the district health information management systems too. And that also looks at the quality, equity, and dignity, that's quality of care network that is supported by the development partners, WHO, IHI, UPORA, USAID, and the other partners. So this scorecard actually ultimately gives an opportunity for scoring, which is the quantitative part, and then there's also a qualitative part, which looks at an action plan, and this is done by about 15 to 20 community members who do this by simple voting, and it's about the majority that carries the vote. It is fully integrated into the community-based health planning and services initiative in Ghana, and they had also supported in resource mobilization and have supported the health system or the health sector with various activities. I would say that currently we have over 1,600 chips that have been trained and being assessed over 8 regions. I'm just told that in the last couple of weeks, it has moved to about 11 out of the 16 regions within the country. Next slide, please. So in the first 2 years, there's been a strong focus on the service in terms of capacity building, the objective 4, which looks at capacity building both at the service and the pre-service. And the focus initially had been more on the service because that is where the patient and community really come in contact. And that is where experience of care is actually exhibited. Now, in 2020, we started working closely to include quality and safety into the pre-service curriculum. And that actually has helped us to identify the gap between the service and complete the academic work. They will be at least of how they should be able to fit into the quality and safety agenda of the country. Now, this brings together professional regulators, the training institutions, and those in service delivery to work together. We have been currently using the WHO patient safety models as part of the getting existing curricula and undertaking quality and safety projects. Next slide, please. So from there, we're looking at the Health Facilities Regulatory Agency, which was formerly called Private Hospitals and Maternity Homes Board. This was established by an Act of Parliament 859 in 2011 to license, monitor, and register both public and private facilities. They have developed the basic minimum requirements for setting up health facilities right from the community-based health planning services up until the quaternary levels. And they assess the infrastructure, the environment, the human resources, the equipment, at the basic minimum standards at each of the levels that they license and they regulate. Next slide, please. So I think that brings me to the end, and I will open up for some other clarification. Thank you very much.
Thank you so much, Ernest. You have illustrated us with a very interesting case in your country. Congratulations for your progress. And certainly, involvement of the high levels of leadership has been an important factor in this experience. Now we are traveling to Jordan. And before that, I would like to remind you to send in your questions. We are very, very interested in hearing from you. So I have with me Carlos Cuellar, who's going to tell us of his long-standing work in Jordan.
Thank you very much. Midori, good morning, good afternoon, good evening. My name is Carlos Cuellar. Thank you all for attending this webinar and allowing me to share the over 20 years of app experience in working in partnership with the Ministry of Health to build their capacity to improve quality of care with a health systems strengthening lens. In a nutshell, Jordan is a country located in the Middle East with a population of 10 million, including 1.4 million Syrian refugees, and 60% of health services are provided by the public sector. Next, please. App's journey started in 1999, and with the support of USAID, we have been supporting 4 projects, and this work has been done in partnership with the Ministry of Health. In the first one, the Primary Healthcare Initiatives project, the focus was on inputs. Basically, what we did was to work on improving the landscape of primary healthcare on both physical plants and equipment, and also some soft interventions, including improvement of clinical knowledge and skills, but basically were inputs. In the second project, we expanded our focus to hospitals and including improvements on infrastructure, physical plants, equipment, but also we started to introduce the concept of quality assurance and add some management support systems, such as information, performance monitoring, and improving the supervision system within the Ministry of Health. But in the next iteration, the HSS2 project, the novelty was the strengthening of quality management systems. So we were kind of more focused on health systems improvements in supporting health service delivery. HSS2 developed, tested, and implemented a service delivery improvement collaborative model aimed at creating a culture of continuous quality improvement in primary health cares and hospitals. And especially on primary health cares, one of the focus was to support them on or preparing them for accreditation issued by the Healthcare Accreditation Council. Building upon on the successes and lessons learned of the precedent projects, the current health service delivery activity has taken the partnership with the MOH to a higher level. Main achievements to date include, first, the upgrade of the improvement collaborative model into an integrated model to respond to changes in the demographic and epidemiological profile. Second, the integration of quality improvements to data-driven performance management systems. And third, intentional contributions to support USAID's journey to self-reliance. Next, please. So what? What are the results of this journey? Today, I would like to refer to one of the main results, which is the change of MOH leadership mindset regarding healthcare quality management strategies. At the beginning of the journey, the prevailing mentality and practice was quality control. The Ministry of Health was conducting their approach using traditional supervision practice, providing training and adjusting processes along service delivery provision. Then the MOH prevailing mindset evolved to quality assurance, more on a more proactive approach and more on of a failure prevention system. This mindset improved and support teams were more focused on the development of guidelines and checklists to assure quality and prevent deviations. However, the largest improvement in terms of quality and performance management came into during the HSD2 and the current health service delivery activity. The MOH mindset progressed to a continuous quality improvement approach that supports team development, is more focused on clients, is a client-centered approach, and evolve into an integrated collaborative model. So in a nutshell, it has evolved from a task-oriented prevailing mentality to a client-centered mentality. The tangible expression of this new mainstream mindset is the integrated service delivery improvement collaborative model that I'm going to refer now. Next, please. This is now the model that has been developed in partnership with the Ministry of Health and supported by the Health Service Delivery Project. In a nutshell, this model supports healthcare teams to go through iterative cycles. Step one of cycle one are baseline, then analysis, defining gaps, planning and review sessions, and then a change package is developed and implemented, and followed by monitoring and evaluation and generating data. Then other 2 cycles follows, and then separated by 3-4 months. The support of a health system is provided through coaching and data modeling. So next, please. These are some of the highlights in terms of quality and performance improvement conducted by the ISDIC project using the improvement collaborative model. And to date, the MOH is widely used and is widely using this model and delivering tangible results in service delivery provision, management integration, and community engagement. In closing, the use of the collaborative model along with systemic interventions is enabling MOH managers and service providers to improve performance and quality in a sustainable manner. It's certainly part of APP's legacy in Jordan. Thank you. Over to you, Midori.
Thank you so much, Carlos. That was really interesting. And I would like to start with a question as we receive more input from our audience that has to do with the perspective of patients and users of the services. We see all these processes of improvement going on within the ministry and the facilities, but what do you think is or are the main features of quality improvement that citizens and patients value? And I would like to link this question to what Soji was saying initially, strengthening or building the trust of the users in the services, in the system. So this is an open question for the 3 panelists, whoever wants to dive in.
Maybe I can start. I think what patients in our experience in Jordan, what patients value the most are 2 things. One is the problem-solving capacity of health facilities, and second is a respectful and culturally sensitive treatment.
Very interesting. What about in your experience, Ernest? Have you been able to measure in some ways the perception of the users, their increased confidence in the system?
We use currently the community scorecard to measure experience of things. I was saying on, we've been able to measure things related to caring, respectful, and compassionate care, things like waiting time. And I must say that based on the experience that we have in Ghana, generally our clients are very excited about they being included in the way service is provided. For example, they are being told exactly what the problems are. They are given the opportunity to choose what they need to do. And so I would say that whenever they have come to our facilities and the waiting time has been reduced, they've been told what the procedure was. We've been able to express things related to compassion, and they've been able to be included and participated in the way care is given. These are the things that excites patients, and this is what they see as experience in quality care.
Okay.
Thank you for that. Soji, would you like to add something from the perspectives of the users?
Well, yes, I was just going to say that the Lancet publication put out some interesting statistics that up to a third, actually, of patients would complain about disrespectful care, short consultations, poor communication, and then long wait times. And it's been interesting to observe how different countries are approaching it. So as structures are created, quality management teams, so to speak, at national and subnational levels, I think there's a move to integrate more and more patients and non-clinician voices into the conversation. And it's interesting that it's been received, it's had mixed reactions in a number of places. Some healthcare professionals do not even appear to be that comfortable. And then there's a whole model around patient and family advisory councils that are also being deployed. I think traditionally, a lot of countries have relied on the patient satisfaction surveys. But as we know, these cannot be that heavily relied upon. They tend to have very high scores because of the unequal power relationship between the clients and the healthcare workers. So there's now the need to move into a more of a partnership model as we redesign the whole care processes to be able to address these issues around privacy, confidentiality, respect, dignity, and then also long wait times.
Thank you for that, Soji, because it's really true that there's a long process to improve quality, but we need to focus on some short-term real differences for people to build that trust. So I have a first question, and this is for Carlos. In Jordan, what were the approaches taken for public versus private services? What role, if any, did NGOs play in this process?
Thank you. APT has worked with both. I just today referred to the public sector project, but also we have worked with other projects through the PSP1 and SHOPS Jordan projects. And we basically worked in supporting private providers on giving them access to training, quality training, and also working with them and trying to aggregate them through professional networks. So the response from the public sector that provides 33% of service have been very positive and responsive to this intervention. They are certainly an important provider, although the integration between public and private, it's still challenging in Jordan. Thanks.
Thank you, Carlos. A very interesting question for all the panelists, but maybe we could start with Ernest. Have you considered using financial incentives to improve quality of services in your country? So what about incentives to introduce quality improvement and sustain these improvements?
But again, looking at the strategic objective number 5 in the National Care Strategy, it's about joy at work environment. And based on our baseline assessment that we did, some of the things that excite the health workers in terms of being incentivized, we're looking at things like the basic and essential inputs that they needed to work with. And that was some excitement when they get everything that they needed to work with. People were looking at things like being recognized, and in some of the facilities that have already started implementing this, they have put, let's say, the portrait poster or picture of a worker in the ward or in the hospital as the best worker for the month, and that also generates a lot of healthy competition that people would like to. Their poster or their portrait be put on the notice board. People are looking at things like the quality improvement team meetings, some kind of refreshment, to also recognize the effort that they are putting in place. A few other people are also looking at the implementation of those recommendations that they make, having gone to the various quality planning tools like mapping the process and finding ways to generate ideas. And these things, management picking them and testing them, showing results and implementing these things across the facility were things that were also forms of incentives and motivators for the staff. And ultimately, financial, support in terms of incentives have also been the things that staff have been looking up to. So really, if we introduce some of these financial incentives, yes, some people are excited, but those who are more internally motivated are looking at the essential inputs and also being recognized in the way that. Thank you.
Thank you, Ernest. And Soji or Carlos, have you had experience in building in quality indicators into payment mechanisms in a way to incentivize these the sustainability of these improvements?
Thank you again, Midori. I would say that the evidence is mixed. in terms of some of these performance-based incentives. What is clear is that many of the countries see health insurance schemes as a pathway to the attainment of universal health coverage. So many initiatives are being undertaken in many places. Pilot studies are happening in multiple countries to be able to roll out viable insurance packages. And closely linked to that is the reimbursement mechanism that comes across. So one would begin to observe how in a number of these countries, they are tying the attainment of quality objectives to those reimbursement mechanisms. So I can cite the example of Ghana, for example, where claims will be rejected on the basis of polypharmacy, on the basis of a mismatch between diagnosis and treatment. And then in many other places, they are all clinical audits to be able to ascertain the evidence base for the treatment that is being given out. But in every one of these places, I think that there's a lot more that could be done to tie the financial and the payment mechanisms to the quality of care. And then, of course, there are the whole slew of interventions around non-financial incentives that I believe NS has also addressed. Thank you.
Thank you. We are getting a lot of questions about the relationship between quality and financing. So I think this is a really interesting area to keep on exploring. As Sergi was saying, there's mixed evidence. There's some difficulties in having the right indicators to link incentives to quality, and maybe Carlos can tell us a little bit about that.
In the case of Jordan, thank you, Miller. In the case of Jordan, I think the policy environment is not conducive to incentives regarding quality. I think there are some challenges, especially due to financial limitations. So I think the way the system is conducted is that Ministry of Health is paying for providing access to services and basically to all citizens, and those who prefer to use the private sector are free to do so. However, there is no monetary incentive, and the only thing that we have worked with the Ministry of Health is more working on the non-monetary incentives, such as reward and recognition of high-performing health facilities.
Very interesting. Thank you. Something to keep thinking about and researching.
Yes.
More work for you guys. An interesting question that came in some places, our audience member says, quality is mostly driven by projects or implementing partners. And there can be a tendency to be vertical, to have a vertical approach. What do presenters recommend for comprehensive health quality that is driven by the authorities and the stakeholders in the countries? Any of you would like to start?
Thank you, Midori. What I would say is that in a number of places where this becomes an issue, where quality is either verticalized in the way it is approached or where it's driven exclusively by projects, it starts from the design. So partners may design their own interventions, get their brilliant results, publish, and then only at the end of the project begin to involve national health systems in a phenomenon that we at IHI have referred to as pilotitis. And it just doesn't work, and it's not sustainable. So really, to be able to reframe the entire conversation, it's important to begin from the design, where we co-design with the countries and make sure that the intervention is very aligned to national level priorities. And then also where there's a need for a hand-holding mechanism to start right from day one, whether or not there's capacity or not, so that we learn by doing together and learn on a pilot basis, learn from what we have done in a small part of the health system, do a good job of documenting what has worked, testing in a variety of settings to build our confidence in the intervention. And then by the time we get to scale, we know that the health system has the ability to be able to support it. There are some strategies that we supported governments to write, And in terms of even the funding of the interventions, making sure that clear budget lines are teased out in the government, health budgets to cater for some, and making sure that over the course of projects, this budget is ramped up so that government begins to plan for some of these interventions outside of the project funds. So for me, co-design is very important. Co-implementation would also be very critical, and then integrating into routine structures. So I know that Carlos spoke eloquently about collaboratives, and we know about the need for peer-to-peer learning networks and the results that one can bring about as a result of that type of network. But there is no health system that we've worked in that hasn't got its own routine review meetings. There are cluster meetings, there are quarterly meetings, there are, half-yearly meetings. These can be totally repurposed to serve the same function. There's no health system that we've worked in that hasn't got managers at the district levels visiting, facilities and then communities. So it's about strengthening the technical capacity to be able to conduct these site-level visits and to provide the support that is needed. So we just all need to just focus on how we can integrate into existing structures so that by the time the programming is executed, those structures are strengthened rather than weakened. The last point that I would make has to do with data systems. So often, we all of us have a choice whether we are going to deviate from the use of national data systems in the name of the fact that they are weak and they are unreliable, and so come up with parallel data systems, or we are going to work with those systems to strengthen them and address incompleteness and accuracy issues. So that would be those would be some of the issues that I would advocate need to be considered strongly if we are to build sustainable programs.
Thank you so much for that. Lots of lessons learned and recommendations that we should try to follow on. We have a very interesting question for Ernest, and I read, can you comment on the extent to which improving health financing and budgets and reducing wastage of health resources, particularly via strengthening anti-corruption initiatives, if these elements have played a role or not in your quality strategies?
Thank you very much. Yes, I think it's quite an interesting question that the participant is asking at the moment. Yes, as far as the implementation is concerned, in our case, the strategy is costed. It's about 40 million, and the Ministry of Health, together with the development partners and other partners, are supporting its implementation. Currently, what we have been able to do in Ghana is that once it's costed, any engagement that we have, we look at the cost implications of that, and then with any agency or any partner that we want to work with, we look at co-designing and co-producing, and then ultimately co-implementing the aspect of either the objective or any aspect of the strategy over the years that we've been working. But of course, some of the challenges that we have also seen in relation to how this implementation is done is how some partners who have a specific interest in vertical programs that look at these things. And I would say that, like Huzi was talking about, in the past, yes, that has been the way that things have worked. But currently, we try to engage in the way that we can look at how the spending of the various funding that is available to the implementation is concerned. So I think this is how we've been looking at it currently.
Thank you, Ernest. A question for Carlos. You mentioned the Syrian refugee influx into Jordan. And the question is, how did the system respond to this increased demand, sudden increased demand? How did the Ministry of Health respond to this external shock? What could you say about resilience and the relationship of the quality of health services and the initiatives to improve quality of services when you have external shocks?
Okay, thank you very much. I think this has very much to see with the evolution of not just our work in Jordan, but also the day-to-day activities at the Ministry of Health. Just to give you an idea, this crisis increased the population in Jordan by 20% in 5 years. If this would have happened in the U.S., it would add 65 million people, the entire population of California and Texas together, or the population of France. Jordan responded in a very generous and, I would say, smart way. They developed a Jordan response plan, which was based on first integration of Syrian refugees into host communities, not to have them in camps. Second, integration of Syrian refugees in the labor market, giving them work permits. And not to all, but those who can, after, of course, a process. And in terms of systems, health, education, and others, they decided not to have parallel systems. Syrian refugees were using the regular health, education, and social services that all Jordanians use, which put a lot of stress in terms of increasing demand, increasing needs, because the populations that came were more vulnerable, and they were bringing issues like more in terms of non-communicable diseases, in terms of children not being vaccinated, and other issues. So what was the response to in the health sector was first to integrate services. Actually, it was a kind of a positive impact of this external shock was the desire to do more integration on the service provision, to do more community outreach activities. Second was to lower the financial barriers to access, to provide to some extent reproductive, maternal, neonatal, child health services free of charge. And third was seen as an opportunity to strengthen the national health system to address the current and future external shocks. So it was resilience is part of the Jordan response plan. Thanks.
Thank you. I'm sure there's lots of lessons learned there that are relevant for other countries. In Latin America only, we have a similar phenomenon into Colombia and other countries. So we should be looking to Jordan for some lessons there.
Absolutely.
Thank you so much for that, Carlos. Thank you for sharing. We have a very interesting question going back to the process of improving quality. This is for Sotyi. The question says, can you comment on how the approaches differ between improving structural quality and improving process quality?
Thank you. Thank you for that. We've often run into this challenge where if one is not careful, one is drawn into a debate about different approaches for improving quality. And I think that if you look at all the global reports that have been issued, including also the one that was produced by the WHO, there is an effort that, as you can see very clearly, to embrace a variety of methods and approaches. And I think that is really the way to go, because no one method is able to address all of the issues. So you may approach it, let's say, from the Labedian point of view and talk about inputs, and then realize you need to address the processes. Another key point that was made and highlighted in the Lancet paper had to do with the fact that the mere existence of resource facilities would not guarantee quality of care. And so one needed to pay as much attention to the processes as to the inputs and to the structures. So I would say that rather than talk about it in terms of, either this or that, it's about the structures and the processes in terms of reducing waste and inefficiencies in the system, in terms of understanding the root causes of the gaps, and rapid cycles of improvement that can be done to address those gaps. And in terms of the structural issues, I mean, we did some work in one village and did quite a lot to be able to get men involved in supporting their wives to attend clinics and hospitals and to deliver in the health facilities. But one barrier that we came across had to do with the absence of a bridge to transport women from villages to the hospital as part of the referral mechanisms when the facilities, could not address the complications. So it really was not about improving little processes within the facility, because we have done that, and yet we have big structural issues to address. So this is where one needs to address some of the bigger leadership issues, accountability issues. So really, in summary, what I would say is that we need all of the variety of methods. Licensing, accreditation, standards-based, continuous quality improvements, a planning framework where resources are clearly aligned to the initiatives to be able to get that large system level impact that we all desire.
Okay, thank you for that. A question for Ernest. Ernest, can you comment on the critical systems that need to be in place to improve quality service delivery at the primary health care level, and how they can differ from what is needed at the hospital or higher referral levels? Ernest, are you still with us? So maybe we could turn that question to Carlos. Do you think there are distinctive features in quality improvement processes at the primary healthcare level in regards to hospitals?
Yes, I think when we're talking about healthcare, we talk about a continuum of care. No? So this, in our experience, this division of what is primary and at least in the case of Jordan and secondary care is not very clear. And the main reason is the existence of an intermediate level, which are called the comprehensive healthcare centers, which are mainly located in urban areas. And that really changed because most of the population in Jordan is urban. So the traditional way of thinking on this continuum, but having gaps on the continuum, has kind of disappeared in a small country where geographic barriers are not present, and with financial barriers that are very, very limited. So I think this notion is not kind of applicable, I would say, to most other developing countries. In the case of Jordan, it's very unique because of geography, because of low financial access issues, and also because of the existence of a continuum that really works and have these three levels in addition to village health centers that and community outreach activities.
Okay, that's very specific to Jordan then.
Very specific to Jordan.
Maybe we could connect with Ernest on this question.
Yeah, thank you very much. I think I lost the line a bit, so I didn't hear the question. Can you repeat the question?
Let me rephrase. The question was related to the difference between primary health care quality improvement initiatives as they could differ or not from similar initiatives at the hospital or higher level referral system levels. So you think it's a different approach for primary health care and a different approach for hospitals?
Thank you very much. So for us in Ghana, our primary health care runs from the community-based health plan services up to the district hospital level. So our primary care is the district hospital, where we are at the moment using the Health Facilities Regulatory Agency assessment tool. The hospital, the primary hospital has the 5 minimum requirements for services, which is emergency care, obstetrics and gynecology, surgery, internal medicine, and pediatrics. And below that one is the health center, and then also ultimately the clinic. So our primary care system, runs from that district hospital level, and then the secondary will be and the secondary and the tertiary will be the upper level facilities. But again, for us, the quality of care runs across. So I would not say that there are any differences. The most important thing is that we set the basic minimum requirements at each of the levels, and each facility is supposed to have what we call a level-specific services that they are supposed to provide. And each of them has the quality indicators that are used on the side of provider and then also on the side of the consumer. But across the levels, from the side of the consumer in terms of the experience of care, those indicators are the same across board. The only difference is that with primary care facilities, in terms of experience, people are probably within the same circle or community, but then at the secondary and tertiary may be the ones that have been referred from the lower facilities to the upper facilities. And we know that already in Ghana, we had some challenges in terms of safe transfer of patients, but currently with the introduction of some new ambulances, to the various districts and constituencies, we're hoping that transfers and referrals are going to improve, from one level to the other. I think that we're also looking at is the reverse or the back referral that has not been really exploited in the past. So, for example, if a patient
has... Very interesting. Thank you. Lots to talk about there, about the system working as one with a continuum of care. And I would like to, really, we are coming to the end of this wonderful webinar. I would like to end with a question to Soji, very briefly. You mentioned a 5-country case study, and I would like to know what are the lessons that emerge from that study, and how is our project, Local Health System Sustainability Project, going to build on those lessons going forward? Very briefly, please.
Thank you, Midori. I think that one key lesson that came from a couple of the countries had to do with these strategies being able to survive political transitions. And the key lesson there was that whilst it's good to have a star, in terms of a political leader readiness, it's even better to situate it within the technocratic structure so that it can live political administrations. And that was key. And as far as LHSS is concerned, I think that we have had some guidance from the USAID in terms of the year's work. And what we're going to do is to learn from everything that has happened. There's great work happening in many places. And what we're going to do is to try and link up in terms of what is working and who is challenged in which areas. So through some global stock-taking exercise, we'll be able to document that. And then also do a better job of sharing lessons across. So some learning network that we're hoping to do. So quite a lot coming on, in addition to all the countries that may come on at a later date. Thank you so much.
Thank you so much to the audience. Thank you so much for the wonderful questions that we got. We will make sure that this discussion is available online. We have recorded it. Just to remind you that this has been the first of 3 webinars in our Working Towards Sustainable Health System series. Watch, please, your email for information or a second session that will be on community health systems, which will be coming up in early March. That's all from us today. Have a wonderful day, evening, or night. Bye-bye.
Bye.
Bye-bye.
Bye.